Once again, thanks so much to those of you who have joined us early. We're going to give it a couple more minutes before we do get started. And thank you to those who have already introduced yourselves in the chat. If you have not done so already, please introduce yourself, include your credentials, your organization, what county you practice in, just so we have a better idea of who's online with us today, and you may be able to make some professional connections. As always, we do hold these during the lunch break, so we're going to give people a couple extra minutes just to finish up their morning patients and join us. All right, I'm sure more people will trickle in, but I do want to get started with housekeeping items. We do have a lot to cover today. So thank you all for joining us, especially for this special National Public Health Week webinar. I'll go over our MAC services, how to receive credit for today, and then introduce our speaker. As you may have noticed, your microphone and cameras are disabled for the duration of today's training to accommodate a large audience. So please make sure that you do have access to the chat. That's how you can communicate with us and with others throughout today's webinar. That's also where you will enter your questions and I'll relay them to our speaker at the end when it is designated time for Q&A. We also now use the MAX Learning Management System. That is how you registered for today's webinar. And that learning management system is great because that is now where you will access the slides, other MAX resources, the evaluation survey, and you can view our other upcoming webinars all in one place. We'll make sure that that link is included in the chat, but we'll also send it out in all of the follow-up emails that you will receive. So please look out for that. Once again, once you fill out that evaluation survey, you will be able to access your certificate. If you are a medical doctor or doctor of osteopathic medicine, your ACCME credits will be entered in the passport within 60 to 90 days, so don't be alarmed if it's not in there right away. If you do get that certificate, that is proof that you did receive full credit. If you have any issues accessing the portal, please reach out to me via email. Feel free to respond to those reminder emails or any of the follow-up emails that you do receive. And now I will go over our MAX services. MAX is funded by the Maryland Department of Health Behavioral Health Administration, so all of our services are completely free to you as providers and other members of the healthcare team. And those services include a phone consultation line. That number's at the bottom of this slide. And it's open Monday through Friday, 9 a.m. to 5 p.m. You can call that line with as patient-specific questions as you'd like. Just make sure that it's de-identified information. You will then initially be connected with our behavioral health consultant who's going to gather some more information about what you're looking for, especially if it is patient-specific, to make sure that it gets moved on to the appropriate consultant, since we do have a panel of diverse specialties on our team. We also offer education and training opportunities similar to today. They are usually during the lunch break because we know you all have busy schedules. This webinar is being recorded and will be available on our website within 1 business week, so look out for that. But we also offer longer trainings, including the PCSS half and half buprenorphine training, which is a really convenient way to knock out all 8 hours of the MATE Act training requirement. We are planning one probably within the next 3 months, if not early fall, so look out for that. We also offer assistance with addiction and behavioral health resources and referrals, technical assistance to practices implementing or expanding office-based addiction treatment services. So that can be anything from finding you an office space to helping everyone in your practice get on the same page about certain protocols or screening tools to use when addressing the needs of patients living with substance use disorders. Another educational opportunity we have are our Max Tele-Echo clinics. Those are collaborative medical education. How that works is you or someone else from the medical community will present a case from your own practice, once again with the identified information. You'll express where you're struggling in treating that patient, and then you'll receive feedback from both other members of the medical community and our panel of consultants. That's followed by a short didactic presentation. So it's another great way to not only get free CMEs, but to also get direct help with the patients that you may need help with. All of our services were included in the chat. They'll also be included in the follow-up email. Please reach out to us with any needs that you have. We are here to support you. I also want to give a brief update on recent legislative changes that do impact you and your practice. So the Maryland Medicaid prescriber enrollment requirement has shifted. So starting July 1st, 2024, Maryland Medicaid will deny all prescriptions from unenrolled prescribers. All prescribing practitioners must enroll as soon as possible to ensure that patients can access Medicaid covered medications at the pharmacy. So basically what this means is if you are not enrolled, your patient may have to go to another provider, especially if you do not get enrolled before they need those medications renewed. There are different options. You can either be a fully participating Medicaid provider or an ORP only provider. So please check out the links that are in the chat. We'll also include this slide in follow-up. This is a really great way for you to stay engaged with your patients receiving Medicaid. And these are services that you should be offering. Now, I know I've been talking a lot, but I do just want to introduce our presenter today. Sarah Whaley is a Senior Research Associate and the Program Coordinator of the Bloomberg Overdose Initiative at Johns Hopkins Bloomberg School of Public Health in the Department of Health Policy and Management. With experience in both opioid treatment and harm reduction research and direct service intervention, her goal as an advocate is to use empirical research to inform policy to improve outcomes for individuals who use drugs and their families. If you do attend a lot of our webinars, you know that it's very rare we have a guest speaker. This is in honor of National Public Health Week. So please tune in, keep your questions in mind, put them in the chat, and I'll relay them to Sarah once it is time. Sarah, feel free to share your slides. Let me know if you need any help with that. I might have to make you a presenter again. And thank you so much for presenting today.
Thank you so much, Bridget, and thank you all for being here. I'm really excited. I'm going to try to share my slides and see how this goes. All right, Bridget, does it look good?
It looks like, yep, we're in presenter mode. This is perfect.
Perfect. All right. Well, today we are going to talk about the opioid epidemic and public health. We're going to talk about the impacts, the interventions, and innovations. So as Bridget mentioned, that was a very nice introduction. Thank you. I'm Sarah Whaley. I am a faculty member at the Johns Hopkins Bloomberg School of Public Health and the program director of the Bloomberg Overdose Prevention Initiative, which is a collaboration between 5 organizations with funding from Bloomberg Philanthropies. We work primarily in 7 states. The Hopkins team does research and evaluation, and then we also have a government support team which helps with policy and technical assistance. I am not a Maryland native, but I have been here for 7 years. I started my career kind of working in direct service, then doing some kind of more macro level social work stuff. I got involved in the research space, and now I'm working kind of at the policy level, translating between research and policy. I live in Baltimore City and am a member of the Baltimore City Women's Commission. So kind of like to stay involved in all of those areas. All right, our objectives for today are to outline the public health impacts of the opioid crisis, to analyze some of the innovative public health approaches to the overdose crisis, and then understanding and exploring the roles of the social determinants of health for the treatment and support of our patients with substance use disorder. All right, section one, we're going to start talking about the impact of the crisis. So first, kind of a history. This is a classic diagram that we see when talking about the overdose crisis. This chart starts in 1999, and I want to just note that people were using drugs before this, and people were using opioids before this. Most of that kind of drug use pre the late 90s was street heroin. And this chart kind of starts in the late 90s following what happened in the 90s when a new issue arose in this country, and that issue was the broad marketing of Oxycontin, so the marketing and use of Oxycontin, which was marked by some misinformation to our prescribers in the U.S. about the addictive properties of these products. And we saw kind of this proliferation of these prescribed pain medications at higher and higher doses for patients across the country. And so that's kind of where we see folks who developed a dependency on these prescribed medications and the rising rates of overdose from those medications. And that's our first wave, is the rise of overdose deaths related to prescribed medication. Our second wave in the 2000s is marked by kind of the response to the first wave. So we had some policy changes to prescribing, crackdowns on pill mills, changes in federal regulation, prescribing caps, kind of all of those things, which led to changes in accessibility for people who had developed a substance use disorder, an opioid use disorder. So when the access to those medications were taken away, we see an increase in illicit opioid use, mainly heroin. So that's kind of our increase in heroin use in the 2010s. Where we are now is the third wave, which again is kind of a response to the wave before. So the increase in demand for illicit opioids and new technologies kind of led to illicit drug market changes and more synthetic opioids like fentanyl and fentanyl analogs. These substances are cheap to produce and are highly potent, meaning that it is somewhat easier for these substances to cross borders because there's not huge packages of heroin, it's smaller packages of fentanyl. So that's where we are now with this increase in synthetic opioids. Some folks also add an addition here. This kind of ends in 2019. There's a potential fourth wave that folks talk about, which is the wave of polysubstance use, which is folks using multiple substances. In 2019, nearly half of drug overdoses, overdose deaths involved multiple drugs. So digging into kind of a little bit more of the current state of the overdose crisis, overdose rates have continued to climb over the last few decades. In 2022, we saw the highest number of recorded overdose-related deaths at over 100,000 individuals lost in 2022. Kind of the breakdown of that, we're going to dig into this graph a little bit. So the black line shows your all opioid-related overdose deaths. And tracking right underneath it, the brown line is fentanyl-related deaths. So kind of similar to what I said, that third wave is where most of our opioid-related overdose deaths are caused by fentanyl and other synthetic opioids. These middle two, the gray and the pink line, are our stimulant class of drugs, so methamphetamines and cocaine. And this kind of shows that relationship of the increase of polysubstance use of folks using multiple substances, including both opioids and stimulants. And then the last thing I want to note here is the bottom two, our green and our blue line. Green line is our prescription opioids and blue line is heroin. So as we think about the current state of the overdose crisis and our policy responses and treatment possibilities for individuals with opioid use disorder, we have to kind of think about the substances that people are using and respond accordingly. And we'll dig into that a little bit later when we talk about treatment. But because the overdose crisis has shifted so much over the last few years, again, our policy and practice interventions need to kind of match what is happening. All right, so as part of this webinar, we have to do some knowledge checks. And I know your mics and cameras don't work, so this is, I guess, something we're going to reflect on internally. Or I guess you could put it in the chat. There you go. Thanks, Bridget. All right, our first knowledge check is the current wave of the overdose crisis, or wave 3, is defined by the increase in overdose deaths related to prescription opioids. Is that a true or false statement? Adrian, I see you said false. Marissa, false. That is correct. It is false. Again, where we are now is the increase in overdose deaths related to fentanyl. I'm going to have an interesting fact because the pandemic changed a lot of things. So in Maryland, we saw actually an increase in prescription opioid related deaths in 2021 and 2022. Which was interesting just because prescription opioid deaths had previously been declining annually every year since 2016, but we saw a bit of a spike. Definitely not as much as fentanyl, but there was like a little increase. I think that has leveled off, but the pandemic had a lot of impacts, and we definitely saw more prescription opioid deaths. All right. Cost of the opioid crisis. We have talked about the extreme loss of life, and that loss of life from overdose deaths has impacted overall life expectancy. So we've seen a decline in life expectancy related to the overdose crisis. There has also been a huge economic cost of this crisis. The Joint Economic Commission report from 2022 estimated about $1.5 trillion were spent addressing the opioid crisis in 2020. And that's the cost of response, but also I think they factored in loss of productivity due to this loss of life. We have also seen some pretty intense societal costs. We have seen an increase in children in the foster care system because of loss of parent or that parent being involved in the criminal justice system. We've seen an increase of incarceration due to drug use. We've seen an increase in homelessness and housing insecurity, and an increase in opioid-related emergency department visits and inpatient stays, a decrease in the labor force participation, so folks being out of the workforce because of a substance use disorder. So overall, a big cost of the opioid epidemic. It has had a big impact on the health of our country and kind of some of these other social factors as well. So what has been happening in response to this? So section 2 is we're going to talk about some interventions. So there are a lot of evidence-based interventions across the continuum of care for people with a substance use disorder. There has been an extensive amount of research in this area. So we have primary, secondary, and tertiary prevention that we know is evidence-based, including kind of primary prevention to stop misuse of substances, secondary prevention to identify problematic use before it becomes maybe a clinical diagnosis, and naloxone that can help reverse an overdose and save a life. We have proven harm reduction programs like syringe service programs. We research around kind of different interventions, overdose prevention sites, all of these things that kind of show how we can reduce the harms of drug use. There's evidence-based treatment, including medications for the treatment of opioid use disorder, our gold standard treatments like buprenorphine and methadone. There are proven recovery recovery programs and supportive services kind of across that continuum, like housing programs and food programs, things that help individuals move into recovery and sustain their recovery. So, with all of this evidence of knowing what works to address this crisis, why do we continue to see increasing rates of overdose deaths? And there's a couple reasons, and we're going to dig into kind of the evidence versus the reality of what the country that we live in and the state of things. So the first example I'm going to share are syringe service programs. This is a harm reduction tool that has been proven over many years to save lives and lower the likelihood of overdose deaths. Just a quick overview of syringe service programs. These are often community-based programs that facilitate the use of sterile drug use supplies and the safe disposal of syringes. These programs can provide also a range of other services, including linkages to substance use disorder treatment, access to and the disposal of sterile syringes and injection equipment, and other forms of safer drug use supplies. But they also provide other healthcare needs like vaccines, testing, linkages to care and treatment for opioid use disorder, but also for other infectious diseases. Born out of the AIDS crisis, they have been proven over the last 30 plus years to have very impactful outcomes, including lowering overdose rates, increasing access to naloxone, greater access to social services and medical treatment, reductions in hepatitis C and HIV cases, care and treatment for hep C and HIV, again, safe disposal of used syringes, and the reduction of sexually transmitted infections. Just in general, studies have shown that patients connected with SSPs are more likely to also receive treatment for their opioid use disorder than peers that don't have a connection to SSPs. So proven to be super effective. However, the reality of the situation is that syringe service programs often struggle to find funding and are closed down, are not able to kind of operate at the capacity that they need to. For a long time, syringe service programs, there were policies around how they can work. There are still states that have policies that prevent the implementation of syringe service programs. So here are just a few headlines from across the country kind of related to what the reality of the situation for this evidence-based intervention is. There are similar discrepancies between the evidence and reality of prevention programs as well. So primary prevention, particularly for youth, have shown to have lots of great outcomes outside of just the prevention of kind of misusing substances. They've shown to increase school commitment and achievement in the long term, have higher socioeconomic attainment, improved mental health. And there are also studies that have shown kind of the multi-generational impacts of kind of these evidence-based prevention programs. But again, the reality of the situation is that these programs often have their budgets cut, and we have also seen kind of the investment in non-evidence-based programming. So being someone who went to school in the 90s, DARE programs were kind of in every school that I knew. All of my friends participated in DARE, and DARE has been proven to not be effective. However, DARE still exists, and there are still jurisdictions that are investing in DARE. And the last one I'll share is in kind of this discrepancy between evidence and reality is access to medications for the treatment of opioid use disorder, or MOUD. So again, our gold standards of care, buprenorphine and methadone, have been shown to have lots of great outcomes, including longer retention in treatments, decreased opioid use, reduction in all-cause mortality, and just general increased quality of life for individuals with an opioid use disorder. Unfortunately, we are seeing that there is still a lot of folks that could benefit from MOUD that are not receiving access. This is a bit of an older statistic, but in 2016, about a third of treatment programs offered MOUD. Newer statistics from 2019 show slightly higher figures of about 50% of SUD providers provide buprenorphine, but less than 20% still provide methadone. And there are still quite a lot of programs that are abstinence-based only and will turn patients away who are utilizing MOUD. 2021, only 1 in 5 patients with an opioid use disorder received an MOUD. And this is kind of a broad statistic, but there are groups that are substantially less likely to receive MOUD. So in particularly Black adults, women, those who are unemployed, and those who live in non-metropolitan areas have a harder time accessing MOUD. So again, why is that? So why is there this big discrepancy between kind of what we know in the science that works and can help mitigate this crisis and kind of what we're seeing in practice? And it is, I think one piece of it is that we as individuals live in society, and that society and the environment that we live in impacts our health. So two terms to kind of present right now are social determinants of health, which are determinants including things like socioeconomic and environmental factors, as well as health-related behaviors. Social determinants of health are responsible for 80 to 90% of health outcomes and are especially important for behavioral health outcomes. Social determinants of health is a term that is used often when talking about populations and how populations are impacted by these environmental factors. Another term to think about are health-related social needs, which are frequently identified as the root cause for disparities in health outcomes. Sometimes health-related social needs are used instead of social determinants of health to really focus on the individual and the proximal causes for poor health outcomes. And when thinking about both social determinants of health and health-related social needs, we have to talk about structural racism. And structural racism has been linked to increased risk of substance use and overdose. Structural racism has prevented communities of color, particularly Black and Indigenous communities, from having equal access to resources that they need to be healthy. Poverty and adverse childhood experiences, intergenerational trauma, and intergenerational substance use are all social determinants of health that are influenced by structural racism. These health inequities experienced by communities of color as a result of social determinants of health and structural racism result in overdose death disparities in communities of color. So currently, kind of where we are in the overdose crisis, the numbers that we kind of saw in the beginning, overdose rates in communities of color are rising at rates higher than that of their white counterparts. But again, as I mentioned, kind of talking about the treatment disparities, these communities are also individuals that are less likely to receive evidence-based treatment. So this is kind of important context for providers as they think about the environment that their patient returns to after leaving their office. And that is an important context to think about in determining like how we provide care. So another kind of broad concept to think about are the risk and protective factors for individuals with substance use disorder. And we can look at those risk and protective factors along the social ecological model, which kind of puts the individual in the context of their environment. So looking at some risk factors at the individual level, looking at the physical and mental health of the individual, the trauma and coping skills. So, in thinking about structural racism, I briefly mentioned adverse childhood experiences. These are called ACEs. They're stressful events that occur in childhood and can include things like witnessing domestic violence, having parental abandonment through separation or divorce or incarceration, a parent who has a mental health condition, being the victim of abuse, being the victim of neglect, being a member of a household with a person in incarceration, and growing up in a household where the adults are experiencing alcohol or drug use problems. So if we think about, an individual that has a substance use disorder, how these adverse childhood experiences might impact them in their future substance use. But a protective factor can be coping skills that we develop over time to kind of deal with some of these traumatic events. Um, Again, things like social emotional learning and skills, and then overall perception of risk. This is something we think about with individuals who are kind of exploring substance use. This is why scared programs don't work, because often youth and adolescents are able to look and be like, well, my friend did drugs and nothing happened to them. So this message of don't do drugs or you'll immediately die or one pill can kill. That's why these programs have been kind of seemingly ineffective with adolescents, is because the risk perception. So the next point on the social ecological model is relationships. So the attitudes and opinions of substance use and substance use treatment. Again, if there's a parent with a substance use disorder, that's impactful. But if you have people in your network that are supportive of treatment, that can be a protective factor for someone. Whether you have a general supportive peer or family network, whether that network knows about naloxone, carries naloxone, that could be a protective factor for overdose. At the community level, the availability of services can be a protective factor or a risk factor if there is not services available. Another piece of this is prescriber attitudes and prescribing practices. So the availability of medication, the access and information around naloxone, general public health education and programming can be a protective factor, and the general economic well-being and housing stability of the community can also kind of be either a protective factor or a risk factor. And then the societal level is both kind of general societal norms and also kind of the policies that are influenced by those societal norms. So thinking about the legislation that exists, whether it's supportive of these programs, like syringe service programs, MOUD, the expansion of behavioral health services. Are there policies that promote racial and health equity? And what kind of insurance and health coverage exists for mental health and substance use treatment? And I skipped over stigma because we are going to dig into that. At the societal level, stigma. So stigma is kind of this balance of looking at substance use disorders either as a chronic medical condition or as a moral failing. I think for a long time in this country specifically, we have looked at it as a morality issue, which is why we have historically criminalized substance use disorder and opioid use disorder. But the tides are changing where it is becoming more acceptable to think about substance use disorder in our society as a chronic medical condition. And kind of we're leaning towards policies and interventions that are less punitive and more supportive. But stigma kind of can result in negative attitudes towards a specific group of people from the general public, and it can have some pretty impactful consequences. So looking at some statistics from a study with NORC and presented in the Associated Press, 78% of Americans still believe that people with a substance use disorder are themselves to blame for their problem. So again, this comes back to that, is it an issue of morality? 72% of Americans believe that people addicted to prescription opioids lack self-discipline. So again, putting it back on the individual and their behaviors. From that stigma, 58% of individuals would not want to work with a person who had an opioid use disorder. This is an interesting one to think about if we are motivated to get people into treatment and into recovery. If we carry this stigma of not wanting to work with someone with an opioid use disorder, where are those folks in recovery supposed to go, right? That's not a welcoming environment when your health condition is this stigmatized. 55% of people would not want a person with opioid use disorder to live next to them. We talked about how housing can be a protective factor, but think about how stigma might contribute to some of those like risk factors. So overall impact of stigma at the societal level, when we have stigma towards people who use drugs, whether it's an individual that carries that stigma, that person might have, some political power and therefore influence policies that block effective interventions for opioid use disorder. This might mean kind of more punitive approaches versus supportive approaches. And we see that often in bans on harm reduction interventions and SSPs. I saw someone in the chat put something, it went by really quickly, but we see that a lot, and that stigma is still very pervasive around harm reduction policies. At the community and interpersonal level, I think this one is important for providers because medications for the treatment of opioid use disorder, there are still many providers that believe that it is replacing one substance with another. It's addiction by another name. At the community level, this can contribute to like NIMBYism, or not in my backyard. So this is community members not wanting treatment programs or SSPs or other interventions and supports for people who use drugs to be in their neighborhood. And at the individual level, all of this community stigma can result in internalized stigma for the person with an opioid use disorder. And this internalized stigma is super impactful because if people believe that there's something wrong with them, or they've failed morally, or they aren't deserving, it can really impact their willingness to seek services and to get help. So kind of working through this stigma is super important because it is very pervasive in our society and has some really drastic consequences. All right, our second knowledge check. Which part or parts of the socio-ecological model is impacted by stigma? Is it just at the individual level, the interpersonal level, the community level, the society level? Joy says all of them. Adrian also says all of them. Carrie says all. And you are right, it is all of them. Stigma permeates kind of all of these layers. Great job. All right, and lastly, I'm moving through. We're doing good on time here. We're going to talk about innovations. So what does all of this mean? So looking at kind of the state of the current opioid crisis, the different discrepancies in the adoption of evidence-based programming, and kind of how risk factors and protective factors are impacted by stigma and kind of permeated throughout our society, impacting the individual. What does this mean for a provider? So I think the most important thing that I want to stress is a reflection on our own biases. I think sometimes folks prickle at the thought of like being reflective of our biases, and we want to think that these biases and stigmas don't apply to us. But all of us carry some, and it's important to know what our biases are. I'll just share a little bit. We'll get a little bit personal for a second. So I had an individual in my family who was impacted by opioid use disorder, and it was hard on our family. And, you know, as a social worker, I was hesitant to, I didn't think that I could be unbiased in working with people who had a substance use disorder because I still carried wounds from like my experiences with that individual in our family. So I had some biases, but I was able to like work through them. And you know, it working through my biases helped me come out the other side. And I think I'm a more compassionate provider because of that. So reflecting on our biases and owning them, I think can be really impactful. Um, and these biases do exist. So studies have shown that biases from providers on people who use drugs can be pretty serious. Folks can be denied medical services. They can have services cut short. Their symptoms or the things that they're experiencing can be downplayed because the provider might think, well, like, of course you're experiencing that. Like, you know, look at the choices that you've made, right? Um, uh, Patients can be blamed for their own health problems because of their drug use. So again, we talked about that like internalized bias and how that can impact people from accessing services or disclosing their drug use to their provider. Providers with a negative bias towards people who use drugs are more likely to misinterpret signs and symptoms that might be related to drug use. They think that it might be the drug use and won't be and may not be like a different medical condition. So we, as providers, may have this bias in thinking that, like, of course, that's the situation. It's because you use drugs, and we don't explore kind of the other health or environmental things that might be contributing to that. Studies have shown that providers who perceive people who use drugs can control their drug use are more likely to believe that these patients are at fault for their health conditions. So just kind of thinking about how our biases can show up and the biases of our colleagues, right? And I really want to point out that like this is a big impact on MOUD access and whether prescribers are willing to prescribe MOUD for their patients, and what criteria the provider believes the individual needs to meet before they're able to get treatment or stay on treatment. So we've seen examples of providers who have stopped MOUD if someone is still using illicit substances. And there might be many reasons for that. And I think we also can look to the example of diabetics are often compared in this comparison of, you know, would you stop a diabetic on their insulin because they ate a cookie? Or do you continue the treatment for that individual? So just thinking about that. And again, a personal example, I'm in physical therapy right now, and I had my appointment yesterday, and I went in and the physical therapist said, did you do your at-homes? And I didn't. But we did them together, and she encouraged me to keep doing my at-homes to rehab my injury. But I think, you know, in a lot of cases for people who use drugs, if they are still using illicit substances or they're not, you know, following their treatment plan, often their treatment can be pulled. And we don't do that for other medical issues. So kind of thinking about how our biases towards that impact the care of the services that we provide. Thinking about social determinants of health and all of that when we are working with our patients, thinking about the whole person. So all of the things that patient may have that is impacting them, the risk and protective factors, what their environment is like, again, when they leave our office, what is their treatment history, what worked for them at one time, what do they need. And even if we don't provide all of those services, thinking about, what kind of connections we might have in our social networks or other provider networks that we can refer people to get help for all of the things that this whole person might need to be successful. And that leads to this one, which is redefining our definitions of success. So again, thinking about, if that patient on an MOUD is still using illicit substances, there is a tendency for, policies of some of these treatment programs that if someone is using substances still, they are kicked out of their program. But for some folks, abstinence might not be the end goal. It might be for some, but it might not be for others. And I'll share an example of a patient that I knew who was on methadone, and she was successfully on methadone for quite some time. But there was oftentimes that she was, still using other substances, whether that was, marijuana from time to time. But there was also times she couldn't get to the methadone clinic, and to not experience symptoms of withdrawal, she used illicit substances, and that would show in her urine screening. And there were times that she was kicked off her program, or had to have treatment team meetings to talk about why she was doing this. And she told me that in these times where she was like having these conversations, or there was a time she was kicked out of her program, was also a time that she was more stable than she had ever been. And so during that time that she was stable, she had applied to school to finish her college degree. She was attending supervised visits with her kids. So she had these like different levels of success, and her stability looked different than kind of what the clinical protocols said. And so my takeaway from that was that, our definition of success can be really binary. It can be really black or white in terms of abstinence, but kind of thinking about what are some of the protective factors that we've increased, even if someone is still using. So kind of to expand our definition of success. 4 is to address treatment gaps. So again, that's that figure of only 1 in 5 people with an opioid use disorder are receiving medication for their treatment of their opioid use disorder. As providers, thinking about how we can address some of these gaps and increase access to medication, if that is kind of what our patient needs or is looking for. In 2023, SAMHSA and the DEA formally announced the elimination of the X waiver. And I heard Bridget talk about some of the trainings that are available to you through Max. So now that clinicians who are currently DEA registrants can prescribe buprenorphine for opioid use disorder. And if you are not I was trying to look at who everyone was in the chat before we got started. But being an advocate kind of for the systems that you work in to increase access to treatment. A recent study showed that only about 50% of hospital systems carry buprenorphine. So being an advocate, if you work in a hospital system, to increase access to treatment, or just an advocate in your community as well. And then the last one I think is important because it is real that working with this patient population can be difficult. It is obviously, we have seen not an easy crisis. It's not an easy medical condition. And there are a lot of factors that impact these individuals. And so as a provider, providers that work with this population do experience a lot of burnout, and it is hard to, I think, see the same patient over and over again for the same thing. And it can be frustrating, that is real, but there is also, I think someone put in the chat, recovery is real. It happens to a lot of people, and it is the goal. And so supporting one another to cope with that burnout, the feelings of helplessness that we may experience as providers. But again, recovery is real. Some studies have been done on providers who participate in MOUD programs and work with people who use drugs. And these studies have shown that providers that get educated, do webinars and things like this, they feel more engaged in the treatment plans with their patients. They feel a renewed sense of purpose in their personal and professional lives. They have less feelings of helplessness. So working with your networks, building each other up, getting educated, and working with these folks can really help to decrease some of those negative feelings. I also think just because this issue is so broad and, like we mentioned, touches kind of all of these different systems, not just the medical system, working with our interdisciplinary partners can be really impactful as well. So we are at the end here, and a few takeaways I just want to summarize for you all is that the opioid crisis has evolved over time and continues to evolve, and our responses and our approaches need to respond to those changes and change with what's happening. Social determinants of health are not a root cause of opioid addiction and opioid use disorder, but they can impact opioid-related morbidity and mortality. Addressing these social determinants of health can improve outcomes for people with opioid use disorder. Stigma has wide impacts from policies to services to social supports and an individual's willingness to seek help. And I think everyone plays a role in addressing stigma. And then the last one is addressing this crisis is going to take interdisciplinary and collective action to create innovative interventions that address the whole patient. All right. Should I stop sharing so that we can get to questions? Thank you all so much for being here.
Thank you so much, Sarah. Please take this time to enter your questions for Sarah into the chat. I know we were getting comments throughout the presentation. Someone connected that Idaho recently appealed their syringe service program. So I think that was the message that you may have seen popped up.
Yeah.
Thank you so much for sharing your personal experiences. I know that encouraged other people to share them in the chat, and I think we all have been impacted, whether directly or indirectly, with opioid use disorder and the epidemic. I'm not seeing any questions come in, but if you do want to reach out to Sarah directly, feel free. If you do want to reach out to us, we're happy to pass your questions on to Sarah. But we are getting many, many thanks. Someone asked, this may have been answered, but why is heroin usage and opioid use separated on the chart?
Great question. So I think, and maybe I can pull it back up, it's showing all opioids, so that includes heroin. And then the chart kind of expanded out to which opioid, so fentanyl, prescription opioids, heroin, and then we also had the two in the middle, which were stimulants, so not opioids, but.
And you'll all receive a copy of the slides so you can refer back to that chart and see what Sarah's referring to. Someone else asked, what percent of decreased life expectancy is due to opioid use?
That's a great question, Carrie, that I don't have that figure in front of me. Yeah.
That seems like it's that would be kind of a hard thing to measure, but we'll see also on our end what resources we have around that. But all those questions are great. Okay, looks like we got another one. How much do you see carfentanil being used? It is now being seen a lot in the detention centers.
Yeah, that's a great question. So I think on that chart specifically, they just talk about fentanyl and fentanyl analogs. Carfentanil I think is not always tested for specifically, but does show up in general. I have not heard a lot about carfentanil related overdoses. It is extremely potent. It's like even more potent than fentanyl. Um, but I know it is like one of the fentanyl analogs that is recorded kind of in that chart. But I don't know. I don't have a figure on like how much. Um,
That's something also our consultants tried to keep up to date with, but it all changes so fast.
It does, yeah. And I think the new emerging, so we've seen increases in xylazine in overdose deaths, but also just kind of the wounds that people are showing up to emergency departments with because of xylazine in the illicit drug supply. I think the new emerging contaminant are nitazines. And I think that is like still super new, and we're kind of still learning what that exactly looks like.
Yeah, we actually just had a webinar on Tuesday that was about some of the new emerging substances, so I'll make sure everyone has access to that recording as well. This next question does seem to be more specific to today's content. Someone asked, for economic costs, are things like drug use related infections and diseases, endocarditis, wounds, etc., taken into account?
I believe so. So there's in my slides, you can link to that the economic report and kind of what they factor into. I think they definitely look at like hospital and first responder data of like when they're responding um, to this and like how they're treating wounds. So I'm pretty sure that is factored in to that cost.
Great, thank you. This next question, and it's okay if you do not, but do you have any studies on opioid recovery around life development and stabilized community for the individual?
I can pull some. I recently did a big literature review with some students on recovery services in general, so I can pull some and share them with Bridget to pass along to you.
Great. Thank you so much, Sarah. That is all the questions that we're seeing. If you do have questions after today, once again, just follow up and we're happy to help. Really great comments and engagement in the chat today. Our Max contact information is in there as well. But please join me in virtually thanking Sarah. Do whatever you can, throw up those clapping hands, say something in the chat. But today's webinar was really great and does count towards that MATE Act requirement. These are really important topics that we touched on. So look out for following messages, fill out that evaluation survey, and please keep in touch. Thanks to you all. Thank you all for being online today.
Thanks, everybody.
All right, Sarah, I'm just going to save the chat and close things out, but feel free to log off. Thanks again for being online with us today.
Thank you. Have a good one.